Okay, now let's talk about alpha thalassemia. Alpha thalassemias, we have the alpha globin gene deletion on the chromosome 16. This leads to decrease in alpha globin synthesis, may have a cis deletion, which is the deletion occurs on the same chromosomes, or trans deletion, which is deletion occurring on the separate chromosome. Normal is we have alpha, 4 alphas, 4 alpha on chromosome 16. That is normal. So alpha, 4 alpha on chromosome 16. That's normal. It often increases the RBC count, in contrast to iron deaf anemia. So in iron deaf anemia, you decrease in RBC count. Increased prevalence in people of Asian African descent, and target cells are seen on the peripheral smear. Let's look at the target cell. Target cell, there's a target that Hunter was targeting. So okay, target cell. Okay, so now let's talk about number of alpha globin gene deleted. So if you were to delete only one alpha gene, then that's called alpha thalassemia minima. Basically, no anemia and silent carrier. They're normal people. They're silent carriers. If you were to delete 2 alphas now, that's alpha thalassemia minor, but depends upon if you have a cis deletion or a trans deletion. Cis deletion on the same chromosome, trans deletion on a separate chromosome. So the cis is, so because of if you have a deletion on the same chromosome, that means the whole chromosome is not working properly, right? So that have a worse outcome for offsprings. So it is worse for offsprings. Okay. But again, and also this is also seen in more commonly in Asians. This is seen in Africans. Okay. What is the clinical outcome? You will have a mild microcytic anemias, microcytic hypochromic anemia, but it's only mild. See, no anemia, mild anemia. You knocked out 1 alpha, you knocked out 2 alpha. Now you have mild anemias. Let's see what's going to happen if you knock out 3 alpha. You're knocking out 3 alpha. So you're only left with 1 alpha and 2 beta, which is normal. I'm talking about beta as being normal. So here what's going to happen is hemoglobin H disease, which is called HBH. Excess beta globin forms beta tetramer. Okay. So what we have is the beta tetramers, which is called HBH, hemoglobin H disease. Beta globins are going to form tetramers. That's it. That is important. Now you had mild up there. Now you have moderate to severe anemia. Now let's knock out all 4 alphas. When we knock out all 4 alphas, now we have hemoglobin Bart's, which has no alpha globin, and you have excess in the gamma globin that forms gamma tetramer. So now beta tetramer were the HBH, Gamma tetramers are called hemoglobin BARTs. Because you don't have any alpha now, this is incompatible with life. Formation of hydrops fetalis. So that's going to cause CHF and will lead to death in utero. Okay, that is just incompatible with life. So that's all for the alpha thalassemias. So it goes from no anemia, mild to moderate, moderate to severe anemia, or just not incompatible with life, depending on 1, 2, 3, and 4, knocking out 1 or 2 or 3 or 4 alpha chains present on chromosome 16. And this is the deletion of alpha globin gene. Now let's talk about the beta thalassemias. Beta thalassemia, you don't have deletion, you have a point mutation. Where? In the splice site or Kozak consensus sequence promoter region. Again, there's a point mutation in splice site or in the promoter region on chromosome 11. Okay, so you have two beta genes on chromosome 11. This leads to, if you have a point mutation, it leads to decreased beta globin synthesis. So you don't have you just decreased the beta globin synthesis, or you have absent beta globin synthesis. It is increased in prevalence in people of Mediterranean descent. So now let's talk about number of beta globin genes mutated, point mutated. So here, if you have one mutation and one normal, you have the beta thalassemia minor. Minor starts from the mild anemia, an increase in hemoglobin A2s. So what is the minor? Again, in minor, you have decrease in beta globin synthesis, so there is a decreased and normal. So decrease in beta globin synthesis, and the other chromosome we have the normal. That's the minor, and that's just mild anemia. On the other hand, if we have decreased in both the globin chains, or one decrease and one absent. Remember, look at these BO and B positive. That's what they're telling you up there. That B plus means that you have a decrease in synthesis, and BO means you have an absent synthesis. So here you have decrease in beta synthesis, or you have decrease on one gene and the other gene is just absent. That's now called intermedia, right? So you're going from decrease to decrease in both of them, and then you're just going to absent in both of them. Okay. In intermedia, you have variable anemia, because this is the disease itself is variable, right? Ranging from mild asymptomatic to severe transfusion dependent anemias. Now let's talk about the other one. What do we have here? We have both the beta genes being absent, so BO, no beta gene. Okay, so that's the beta thalassemia major. Colles anemia. You have severe anemia with target cells, increase in NSO-poikilocytosis. That I'm trying to see what that means, but let's see. I've mentioned that. Okay, give me 1 second. Different sizes. That means just that you have different sizes and shapes of RBCs. Okay. Now this requires blood transfusions, increased risk of secondary hemochromatosis because of the transfusions. Marrow expansion will give you a crew cut on skull X-ray, crew cut appearance on skull X-ray, which it would lead to skeletal deformities and extramedullary hematopoiesis, which leads to hepatosplenomegaly. Because of extramedullary hematopoiesis, spleen and liver is going to start forming your RBCs, leads to enlargement of them, leading to hepatosplenomegaly. There is an increased risk of parvo B. Whenever we have a problem in RBCs, then we have they're prone to getting infected by parvovirus, which is B19. That would induce aplastic crisis. Okay, and you have increase in HbF, which is and fetal hemoglobin. So this is just a compensatory mechanism, and the body is trying to have some sort of RBCs, some sort of hemoglobin. So they're trying to make NHbF. NHbA2 becomes symptomatic after 6 months when HbF declines. So basically, in a child, a newborn would not show any symptoms, but after 6 months they will start showing the symptoms because you will have a drop in HbF. And HbF is productive because HbF is working pretty good. They don't need no well, what was the HbF made of? Can you guys tell? Oh, let me just open. Yeah, it was made of alpha and gamma. So HbF was alpha 2 and gamma 2. So they don't need the betas, right? So that's why we even give the drug to increase HbF in thalassemic patients. And in a newborn, till 6 months, you don't even know that they have thalassemia because it's working great for them. Everything is good. But after 6 months, decline of HbF occurs, and that is when you see it. Also, you have a chronic hemolysis, which would lead to pigmented gallstones. Chronic hemolysis. So reticular endothelial cells, they will see the target cells as seen here. They will try to hemolyze them, leading to hemolysis, and so much so that you will have gallstones. Okay, now let's talk about this one, which is sickle cell beta thalassemia. In here you have decrease in beta production, and the other one is just that is the sickle cell HBS, or you have no production of beta cell, and then you have the sickle cell disease with that. It is mild to moderate sickle cell disease, depending on whether there is a decrease in production of the beta cell or absent in the beta cell. Beta globin synthesis. Okay. So now let's just have a summary here. And if you were to summarize, if we knock out one beta gene, the other is working fine. So you have a normal, minor is called now minor, and major means you knock out both the beta genes. So in the minor, you just have myelonemia, and compensatory, you have increase in HbA2s. And what was HbA2? If you guys can tell, HbA2 is alpha 2 and delta 2. I don't know if they have it in the picture, but that's what it is. So composition of inclusion H2, HbA2. So the first one, knockout one, beta thalassemia minor, mild anemia. Second one, you are knocking out both of them with a point mutation, and that's going to give you severe anemia, extramedullary hematopoiesis, which is going to give you crooked appearance on the chest X-ray, not chest X-ray, but skull X-ray, hepatosplenomegaly, increased risk of B19 virus infection, which will give you aplastic crisis, increase in HbF. There's decrease or not even present HbA1. Okay, and you have compensatory increase and also in HbA2. And up top on this one, you have, here you had none of HbA1. Over there, you just have decreased production of HbA1. Yeah, okay. So that's some other points to mention about thalassemias are. So the presence of erythrocyte precursor cells in organs, for example, liver, spleen, indicates extramedullary hematopoiesis, which is a condition characterized by EPO, erythropoietic, I don't know what EPO. Can you tell what EPO was? Erythrocyte progenitor regions. I don't know. It stimulates the RBC production, right? Erythrocyte. EPO would stimulate the RBC's production normally by the bone marrow. But since we don't have anything there, this EPO is going to stimulate the extramedullary organs, marrow cells in extramedullary organs, in spleen and liver. Okay. And here, marrow expansion on the crooked non-skull X-ray will thin the bone's cortex and can impair bone growth and also causes pathological fractures. And this is not only the skull but also the vertebrae. Now let's talk about the treatments of this. The treatment, you are giving blood transfusions. Those blood transfusions are needed for the adequate to give the adequate levels of hemoglobin, right? And these patients who are receiving blood transfusion should also remember you're giving blood transfusion, but the RBC life is 120 days. They will be destroyed and iron will be released. That iron will accumulate in the body, leading to hemosiderosis. So how can you prevent that to happen or delay that process? Is by giving iron chelation therapy to decrease the overall load of iron, and that is occurring coming from either blood transfusion or also the hemolysis of RBCs. Because this iron, when it is overloaded, it is going to get deposited into tissues. If it gets deposited in It will get deposited in the liver, the myocardium, the skin, the pancreas. In the pancreas, when it deposits, it causes bronze diabetes. And you can look at this hemosiderin accumulation by doing the Prussian or Persian blue stain. So you give iron chelation therapy to fix this issue. Okay. So I guess that's pretty much it for the beta thalassemias. But overall, just looking at the minors, whenever you see beta thalassemia minors, they do nothing. There's nothing for that. But if you see some major, then you're looking at transfusion and giving iron chelation, which is the deficit rocks. Iron chelation.